Hello everyone, I'm Sanjiv Agarwal. I'm an orthopedic consultant in Cardiff in the UK. I'd like to thank Professor Kumar for asking me to participate in this seminar. Let me bring up the first slide. So we're going to talk today about surgical approach to chronic joint dysfunction, which in simple terms means surgical approach to arthritis of the joint. Now, just a little bit about myself. So I work in Cardiff, which is the capital of Wales. This is the hospital where I work. In simple terms, if we talk about chronic joint dysfunction, it means management of the arthritic joint. As a matter of example, I have chosen the knee joint, and that's for two reasons. The first thing is that the knee joint is a large part of what I do in my practice. And secondly, the surgical treatment of knee joint really exemplifies the variety of treatments available to the surgeon to deal with arthritis. So the way we approach management of arthritis in the knee can be summarized into what we call a reconstructive ladder. And this is a list of all the interventions possible for dealing with knee arthritis. If you look at this ladder, the total knee replacement, which is a common thing that comes to mind when we think about knee arthritis. So this operation is somewhere in the middle. Above total knee replacements are the more invasive procedures, and this includes hinge knee replacements or replacing part or whole of the femur. Beneath the total knee replacement are the less invasive interventions. And these start from arthroscopic debridement to cartilage regeneration, osteotomies, or partial knee replacements. So what I'm going to do today is to go through the less invasive options for management of knee arthritis, ending probably at total knee replacement. I'm going to leave the more invasive aspects because they are more really a specialist topic. So let's start them one by one. And I'd like to pick up first on arthroscopic debridement. So arthroscopy essentially means putting a camera inside the joint. It is done by making two small cuts in the front of the knee. They're less than a centimeter in size. The camera goes from one side, and then we can push an instrument from the other side. And that gives us an opportunity to look at the surface of the knee joint and to remove any small bits of cartilage that might be loose or might be having some flap tears, for instance. So the picture on the left shows a relatively normal looking knee joint surface. You can notice that the surface is smooth, it's nice and white, and there are no irregularities. The picture on your right shows there is some irregularity on the surface. It is obviously very different to the picture that you're seeing on the left. And this picture on the right is where there is exposed bone on the surface of the femoral condyle. Some people may have meniscal tears, and this is an example of that. This is the medial meniscus, and it looks very frayed in the picture on your left. The picture on the right shows the tear is after it has been excised to a stable edge, and this often helps people with their symptoms. Now, it's got to be borne in mind that arthroscopy is a good treatment for people with degenerate meniscal tears who are not responding to non-operative treatment. So we should always advise a period of non-operative treatment, which normally is about 3 months. And if they don't respond to that, along with physiotherapy for 3 months, then we'd consider doing a removal of this meniscal tear through an arthroscope. It does not work very well for people who have got advanced knee arthritis, as shown in this X-ray. So if you look at this and you see the gap between the femur and tibia on the medial side, which is to the left of your screen, then you see the gap is very narrow compared to the lateral side, which is to the right of your screen. On the lateral side, the gap looks good. On the medial side, the gap is narrow. And this person has got advanced knee arthritis. This is not something that would respond to arthroscopic debridement. It needs something a little bit more than that. This brings us to the next rung in the ladder, and that is cartilage regeneration. Now, cartilage regeneration seems like a good idea. And that's because in arthritis, what is happening is that the cartilage is being worn out. And if there was a way to reconstruct that, then it certainly should be useful. So cartilage regeneration works very well, but it works well in very specific reasons, specific indications. So this is one example. This is a relatively young person who has got a post-traumatic defect in the cartilage, as you can see in the center of the picture. Post-traumatic means this person has had an injury, and as a result, a part of cartilage has been knocked out from the femoral condyle. So this has been exposed through a small incision, and this is a scaffold that we can use to cover this defect. This scaffold is made of collagen. It's quite expensive, so this one in our hospital costs about £2,500, and this scaffold is about 2 by 3 centimeter in size. So you can cut the scaffold to the shape of the defect and then put it in the joint. That's the scaffold being placed onto the surface, and it's fixed in place by some absorbable darts, and they are called smart nails. Once it's done, the cells from the bone will populate this collagen scaffold, and they will transform to cartilage cells. They will lead to formation of cartilage, which will cover the defect. So in theory, it's a good idea. The problem is twofold. Number one, the cartilage which is formed by this method is not exactly the same composition as normal cartilage, and hence it's not as durable. Secondly, for this thing to work, the surrounding cartilage has got to be normal. So if the whole surface is worn out, then this method would not be very effective. So it works very well, but only in relatively very limited indications, and these are more common in younger people. So that shows the defect which has been covered. The little dark areas are the absorbable nails that have been used to fix it in place. So that's about cartilage regeneration. The next thing is called a realignment osteotomy. So as you can see, we're getting more and more invasive in our interventions. And this is an example where a realignment osteotomy might work. This person, the right knee, you can see has got a fairly bowed appearance as opposed to the left knee. So what's happening here is, if you draw the mechanical axis of this person's limbs, then the red line shows the mechanical axis. If you look on the left side, on the left leg, the axis passes through the center of the hip, center of the knee, and center of the ankle. And this is what is normal mechanical axis. The X-ray of the right leg shows that the mechanical axis is passing medial, on the medial side of the knee joint. And this will put more pressure on the medial side of the joint, leading to arthritis, leading to pain, and leading to accentuation of this deformity. So what we could do is to correct the alignment, because in this situation, the malalignment is the underlying problem. That can be done by correcting the shape of the tibia. And this is how we do it. So you make a cut on this inside of the knee, you cut the tibia and open it up on the medial side, and then we put a plate to hold it together. So this is what it looks like. The X-ray on the left is the preoperative picture, and this shows slight varus of the knee, and the picture on the right shows the alignment after correction. So you can see the medial side of the tibia has been cut and it's been opened up. The plate stabilizes the osteotomy, and the alignment of the tibia now is more valgus compared to the preoperative alignment. As a result, the weight-bearing axis is now shifted more to the lateral side of the joint. So this offloads the medial side and release the pain that the person might be getting from medial arthritis. So osteotomies work very well, but the indication for them is when there's a primary abnormality in alignment, which we can correct. If the alignment is normal and the person has got arthritis, then osteotomies may not work very well. We normally use them in people who are relatively young. So relatively young for this operation means under the age of 55, and who are relatively more active or involved in occupations that require them to be on their feet for a long time, or they would like to exercise more than what more elderly people would like to. They work very well. In terms of how long they last, they can last about 10 years or maybe longer. And once the person gets arthritis in the remaining part of the knee, then they would be suitable for a total knee replacement. So the advantage of doing an osteotomy is that it will delay the need for total knee replacement by 10 to 15 years. And that often is a good thing in someone who's around the age of 50 years. Now, going up the ladder, the next step would be a partial knee replacement. Now we are getting in a situation when the knee is quite advanced in terms of arthritis, and one compartment of the knee has got fairly advanced changes. So we think of the knee joint as a composite of three compartments. There's a medial tibiofemoral compartment, there's a lateral tibiofemoral compartment, and there's a patellofemoral compartment. So three compartments. Each of these three compartments could have arthritis on its own. It is rare, so about 25% people may have isolated arthritis on the medial side. The arthritis on the lateral side is quite rare, and about 1% people will have arthritis localized to the lateral compartment. As regards the patellofemoral joint, 5 to 10% people may have arthritis which is predominantly in the patellofemoral joint. So if we have a patient who has got arthritis in only one compartment, it is possible to replace only that compartment. And the advantage of doing that is it preserves the rest of the knee, it preserves the cruciates and the collateral ligaments, so the kinematics of the knee is more normal as compared to a total knee replacement. So you get good function, slightly smaller operation, good pain relief. So this is an example of a replacement of the medial side of the knee. So this person has got completely advanced arthritis, so bone on the medial compartment. There's no cartilage remaining. And the picture on the right shows a medial unicompartmental replacement. So the cruciate ligaments sit in the center of the knee and they are preserved. The collaterals are on the sides and they are preserved. This is an example of a lateral compartment arthritis, which has been managed with a lateral unicompartmental replacement. Similar to medial, although it's much less common as compared to the medial arthritis. And this is an example of replacement of the patellofemoral joint. So we put a small metal bit on the front of the femur, which is called the trochlear component. We put a small plastic button behind the patella. These two bits are normally cemented in place, and this replaces the patellofemoral joint. Again, the cruciate and the collateral ligaments are preserved, so the kinematics of the knee is same as a normal knee. So these are partial knee replacements. They work very well again in people who have got arthritis localized to one compartment. Now, there is a possibility that the rest of the knee may get arthritis in due course. And if that happens in 5 years, 10 years, 15 years time, then these replacements can be removed and we can put a full knee replacement in. Again, the advantage is that as long as they last, the full knee replacement surgery has been delayed by that much time. And that brings us to the last option for the purpose of this conversation, and that's a total knee replacement. It's a fairly common operation. We talk about it a lot. A lot of people have knee replacements. In the UK, we do about 85,000 knee replacements every year. So it's fairly common. And this is a typical example of a knee replacement. Fairly advanced arthritis, as you can see. The medial compartment has got bone on bone. The lateral compartment is disrupted as well. And there's a gross varus deformity in this knee. And you can correct this and restore the alignment using a total knee replacement. And you see the knee is nicely balanced. The implant is well fixed and well aligned. There are various ways of doing knee replacements. Most knee replacements are done using traditional methods, using a jig which fixes onto the bone, and that helps us to guide where the resection of the bone is done. You can do it by using computer navigation, which I've done for the last 15 years or so. And in this, there's a computer system in the theater. There's a camera, and the camera senses the position of these little balls that we implant on the bone. And on that basis, it guides where the resection is done. It makes it more accurate. It makes balancing more reliable. And it is a very useful tool, and certainly in some situations where traditional methods cannot be used. Another method is to have patient-specific jigs made. What we do in this method is to have an MRI scan of the knee prior to the surgery. We then make 3D printed plastic blocks which are sterilized and are available at the time of surgery. The knee is opened up and these blocks are placed on the bone to make the resection. Again, it makes it slightly more accurate. It shortens the operating time, so it makes the operation a little bit quicker. And you get good results, good balancing, and good alignment with this. And again, this technique is in common use in our center. The next step beyond that is to have the knee replacement implant specifically made for the person. Now, when we use computer navigation or when we use patient-specific jigs, the implant is still off the shelf. So there are about 5 or 6 different sizes of knee replacements, and we have to choose one of those that will fit in that person. The pictures on the left show that she can have a knee replacement made for that individual person. And this is 3D printed. It is based on a preoperative CT scan, and the implant takes about 6 weeks to manufacture. It is sent from the company, and then that's put inside the patient. The advantage of that is that the curvature of this implant and the balancing it will give you of the ligaments and the soft tissues cannot really be matched by a standard off-the-shelf implant, and hence you get really good balancing, really good function after this. It is a relatively recent technique. It's been around only in the last few years, and our experience with this is still developing. But what we find in our initial experience is that the stability you get from this is exceptionally good. The picture on the right shows your robot, and we now have robotic knee replacements available. The robot helps to, again, make it more accurate. We use traditional implants when we use the robot, and it just makes it a little bit more exciting doing knee replacements. So we're going to stop the reconstructive ladder at that point. Beyond the top half of the ladder, as I said, includes more invasive procedures, and they are needed when knee replacements have been done and they've failed, and you have to go back in and revise them. And we'll leave them for another day. So to sum up, my thoughts are arthritis of the knee is quite common. We have a lot of interventions available that can be dealt with. The concept of the reconstructive ladder is that the patient enters the ladder at the right level. So someone who needs a partial knee replacement will not be served well by an arthroscopy. So that's one. And the second thing is that we want to prevent people from progressing up the ladder. So we don't want to be doing repeated interventions in people. We want to choose the one operation that will work well. In terms of recovery from knee replacements, most people take crutches for about 3 or 4 weeks, and then they can come off the crutches. Full recovery takes between 2 and 3 months. The results are exceptionally good. About 5 to 10% people may have some degree of ongoing pain, but generally, if you see its satisfaction rate, it's over 90%. So I believe that sums up what I want to say about surgical management of knee arthritis. If there are any questions, I'll be more than happy to answer. Thank you for your attention, and thank you for joining in.